If you're over 60, I want you to think about whether your feet have felt different lately. Not painful, different. A numb patch that comes and goes. A dry heel that doesn't respond to any cream you've tried. A small cut that took longer to close than it should have. I need you to hear this clearly. Right now, more than 8 million Americans are living with diabetes and have absolutely no idea. Not because they haven't been paying attention, not because they haven't seen a doctor, but because the warning signs their body has been sending, through their feet of all places, look exactly like getting older. They look like dry skin and cold toes and a foot that falls asleep. And because they look like that, people explain them away. For years. Today, I'm going to show you 9 specific signs that high blood sugar leaves in the feet, what each one actually means inside your body, and what to do about it. By the end of this video, you will never look at your feet the same way again. The reason I'm making this video is because of how many patients I've watched walk into my office, or worse, walk into an emergency room, who had every single one of these signs already present, for months, sometimes years, having explained every single one of them away. I want to tell you about one of those patients. His name was Robert. He was 67, retired, and genuinely active. He walked his dog every morning. He watched what he ate. He wasn't overweight by any real measure. He came in for a routine checkup. And almost as an afterthought, at the very end of the appointment, he said to me, "My feet have been a little numb lately. I figured it was just age." I ordered a fasting blood glucose test. His result came back at 214. For reference, anything above 126 on a fasting test is diagnostic for diabetes. Robert had been diabetic, by our best estimate, for over 2 years. 2 years of his body communicating through his feet. 2 years of him explaining it away, because what he was experiencing looked indistinguishable from normal aging. He is not unusual. He is not the exception. Robert is the rule. What I want you to carry into the next 20 minutes is this. The feeling of being fine is not the same as being fine. Your feet can show you what your blood tests haven't found yet. And after today, you'll know what to look for. 2 things before we start. First, there are symptoms in the feet that aren't early warnings. They're emergencies. If you have a wound or sore that has been open for more than 2 weeks without improving, call your doctor today. If your foot is hot, red, and suddenly swollen without a clear reason, that is same-day attention. If any part of your foot has turned dark, black or blue, without an injury, please stop watching and seek care right now. None of those apply? Good. Here is the framework that ties everything together. Every sign I'm about to show you traces back to one of 2 pathways. Pathway 1, your nerves. Chronic high blood sugar slowly erodes the protective coating on the long nerve fibers that travel from your spine all the way to your toes, the longest nerve fibers in your body. As that coating breaks down, the fibers begin to misfire or go completely silent. Pathway 2, your blood vessels. High blood sugar accelerates the narrowing of the small arteries below your knee, reducing circulation, reducing oxygen delivery, and reducing your body's capacity to heal itself. Every sign on this list is a product of one or both of those 2 pathways. Damaged nerves, narrowed vessels. That is the whole story. Let's go through each one. Sign number 1. I want to frame this carefully because I need you to recognize it. Not because it's unusual, because it's so familiar that almost everyone already has an explanation for it. My foot just falls asleep sometimes. I was sitting with my legs crossed. Or, there's a numb patch near my toes in the morning. I must have been lying on it funny. Those explanations aren't always wrong. Feet do fall asleep. Pressure does cause numbness. But here is the specific distinction that matters. Positional numbness has a clear cause. You shifted position, stood up, and it fully resolved within a minute or 2. What I'm describing is different. It tends to affect both feet, not just one. It begins in the toes and the ball of the foot, not the heel. It doesn't fully clear when you change position, and it is consistently worse at night when there are fewer distractions pulling your attention away from it. This is damaged nerve fibers doing what damaged nerve fibers do, sending incorrect signals that your brain interprets as tingling, buzzing, or that pins and needles sensation of a limb going to sleep. Except it isn't your position causing it, it is the fibers themselves. Here is the number I want you to hold. Loss of protective sensation in the feet, often with the person feeling nothing at all, not even the tingling, increases lifetime risk of a serious foot wound by approximately 7-fold. Tingling is a warning. Complete silence, no feeling whatsoever, is not safety. It is deeper damage. If this pattern is familiar to you and a blood glucose test is overdue, that alone is reason enough to book one this week. Sign number 2. This one is harder to explain away because unlike numbness, it interrupts sleep. The most common things I hear are, I get this burning feeling in the bottom of my feet at night. I figured it was restless legs. Or, my feet feel like they're on fire in bed. I assumed it was poor circulation. Both are understandable explanations, but here is the specific distinction you need to know. Restless legs produces a deep crawling or pulling sensation in the muscles, and it is typically relieved by getting up and moving around. What I'm describing lives at the surface, in the skin of the soles and toes, not deep in the muscle. It does not improve when you get up and walk. It is often briefly relieved by something cool and made worse by warmth. And it follows a very specific distribution, the soles and the toes, because those areas are served by the longest nerve fibers in your entire body, the ones that sustain damage first. A 2025 meta-analysis covering 41 studies found that nearly half of all people with diabetic nerve damage experience this burning pain. Older age, higher BMI, and longer duration of untreated elevated blood sugar all significantly increase the risk. If your feet have been burning at night, specifically in the soles, and a blood glucose test is overdue, those two facts together warrant a conversation with your doctor. Not new bed socks, not a different mattress, a blood test. Sign number 3. I need you to sit with this one, because this is the sign that causes the most serious, most preventable harm. What patients tell me is, I had a little blister on my heel from my new shoe. I put a plaster on it. It's taking a while, but it's not infected. Or, I nicked my toe trimming my nails, and it's still not closed. I figured that just happens when you get older. Those explanations are completely logical. But here is what is actually happening. Chronic high blood sugar impairs your immune response at a cellular level. It slows the white blood cell response to damaged tissue. It restricts oxygen delivery to the wound site. It reduces your body's ability to form the new blood vessels needed to repair the injury. And critically, because of the nerve damage we've already covered, many people with elevated blood sugar feel little or no pain from these wounds, which means they walk on them, day after day, without realizing. A small blister that would close in 3 days for most people can, in someone with untreated diabetes, become an open wound within a week, and then something deeper. Here is the statistic I want you to understand clearly. 85% of all lower limb amputations in people with diabetes are preceded by a foot ulcer. Not a serious infection that appeared from nowhere, a wound that started small, that was explained away, that was given more time. If you have a cut or sore on your foot that has not closed in 2 weeks, that is not a wound that needs more time. That is a wound that needs a doctor. Not next week, today. Sign number 4. This is the most easily dismissed sign on the entire list, because every moisturizer advertisement, every pharmacist, and every well-meaning family member will tell you that cracked heels are a moisture problem. And sometimes they are. But here is something almost no one has been told. The sweat production in your feet is controlled by a specific type of nerve fiber, autonomic nerve fibers, the same family of fibers that regulate your heart rate and blood pressure. Diabetes damages these fibers too. When the autonomic nerve fibers that serve your sweat glands are compromised, those glands stop receiving the signal they need to function. The skin of the foot begins to dry out, not from the weather, not from dehydration, not from the wrong soap, but because the nerve signal that tells your skin to stay moisturized has been disrupted. The body stops moisturizing itself from the inside. Cracked heels in this context are not a skin problem, they are a nerve problem. And the reason this matters clinically isn't just comfort. Cracked skin creates entry points. In someone with reduced circulation and a compromised immune response, which is exactly the situation in unmanaged diabetes, those entry points become infection pathways that are far harder to close than the crack that opened them. If you have been applying heel cream every night for months with little improvement, I want you to hear this directly. The problem may not be in your skin at all. It may be in your nerves. Sign number 5. The explanation I hear for this one is nearly universal. My feet have always been cold. That's just how I am. I wear socks to bed. I understand that completely. Chronically cold feet are so common in older adults that most people have accepted them as a personal trait rather than a symptom. But here is the clinical detail that separates background coldness from something worth investigating. The coldness that concerns me is present in the morning, not just after a long day. It is there in summer, not just winter. And it is often uneven, one foot noticeably cooler than the other, or accompanied by skin that looks slightly pale or thin. That pattern is a sign of reduced arterial blood flow, specifically a condition called peripheral arterial disease, or PAD. High blood sugar accelerates the thickening and narrowing of arterial walls, a process that in diabetes preferentially targets the smaller arteries below the knee, the very vessels supplying your feet. Less blood reaching the feet means less warmth, less oxygen, and significantly less capacity to heal. In people with diabetes, PAD is present in somewhere between 20% and 50% of individuals over a lifetime, and it contributes to 50 to 70% of all serious foot complications. It is not background noise. It is one of the two main pathways to amputation. If your feet are persistently cold, and especially if that coldness is uneven between the 2 feet, please mention it at your next appointment. Not as an afterthought, as a symptom you are specifically reporting. Sign number 6. My ankles are swollen. I've been on my feet all day. Or, they puff up in the afternoon. I figured it was the heat or just sitting too long. And I want to be fair. Positional fluid accumulation in the ankles is real, common, and often completely benign. But there is a specific pattern that I pay close attention to clinically, and it is different from end-of-day puffiness. The swelling that concerns me is present in the morning as well as the evening. It affects both ankles symmetrically, and it leaves a visible indentation when you press your thumb firmly into the soft tissue just above the inner ankle bone and hold for 5 seconds. That is called pitting edema. In the context of diabetes, this pattern can signal something your doctor needs to know about: early kidney involvement. Diabetes is the leading cause of kidney failure globally, and the kidneys begin to be affected quietly, long before a formal diagnosis. When the kidneys start to struggle with fluid balance, one of the first places that fluid appears is in the ankles. The swelling is not in your shoes, it is in your blood work. Here is the self-check I give every patient. Press your thumb firmly into the soft tissue just above your inner ankle bone, hold for 5 seconds, and release. If the indentation stays visible for more than a few seconds, that is worth reporting to your doctor. Not as background, and not as "my ankles seem a bit puffy," as a specific symptom described in those words. Sign number 7. When I mention toenails in the context of diabetes, the response is almost always, "I've had fungal nails for years, that's just athlete's foot." Let me be clear. Fungal nail infection is extremely common in the general population and does not on its own mean you have diabetes. But here is what a 2024 study from a primary care cohort found after adjusting for every other contributing factor. Onychomycosis, fungal nail infection, is independently associated with foot ulcer development in people with diabetes. not as a coincidence, as a direct pathway. The mechanism is this: thickened, discolored, or separated nails create pressure points on the nail bed that, combined with the reduced sensation from nerve damage we have already discussed, can produce wounds the person never feels. They walk on those pressure points for weeks without knowing. There is also a shared driver between diabetes and fungal nail infections: impaired immune function. A body struggling to regulate blood sugar is simultaneously less equipped to fight off a fungal invasion. The nail changes themselves: thickening, yellowing, separation at the edge, brittleness can also reflect the reduced blood supply to the nail root that comes with peripheral arterial disease. If your toenails have been thickened or discolored for more than a few months, and a blood glucose test is overdue, those two facts together are worth a conversation with your doctor. Not separately, together. Sign number 8. This is the sign almost nobody has heard mentioned in connection with diabetes, and I want to approach it carefully because by the time it becomes visible, it has already been progressing for some time. What patients describe is, "My shoes don't fit the same as they used to," or "The ball of my foot looks different. I assumed my feet were just spreading with age." What they are sometimes describing, without knowing it, are the early stages of a condition called Charcot foot. When nerve damage becomes severe enough that the foot loses its normal protective sensation, the bones and joints are subjected to mechanical stresses they can no longer detect or respond to. The arch begins to collapse. The foot widens and shifts shape. In its earliest phase, when it is still fully treatable, there is localized warmth and swelling without an obvious injury. Most people assume a mild sprain and wait. In its later stages, the structural changes cannot be reversed. The foot takes on what clinicians call a rocker bottom shape, and that shape is permanent. Here is the outcome I need you to understand clearly. In patients with Charcot foot who develop a foot ulcer, the amputation risk is approximately 50%. Compare that to roughly 10% in people with diabetes who do not have Charcot. The early phase is manageable. The late phase is not. If the shape of your foot has changed in a way you cannot explain, or if your shoes have stopped fitting the same way without an obvious reason, please do not put it down to age. Sign number 9. I saved this one for last, not because it carries the highest immediate risk, but because it is the sign almost nobody has been told to look for. In years of practice, almost every patient I've shown this to has said some version of, "I never noticed that. Should I have?" Here is what I'd like you to do right now, if you're somewhere you can check. Look at your lower legs, from the mid-shin down to the ankle. Then look at the tops of your feet. If you once had noticeable hair in those areas, and it has thinned significantly or disappeared without an obvious reason, that is a sign of chronically reduced arterial blood flow to the lower extremity. Hair follicles require a steady blood supply to remain active. When circulation to the lower legs and feet is persistently reduced, the follicles in those areas are among the first structures to quietly shut down. The change is gradual, which is exactly why it goes unnoticed for so long. And because leg hair thinning has so many cosmetic and age-related explanations, it almost never triggers concern on its own. But in the presence of other signs on this list, cold feet, slow wound healing, persistently dry skin, lower leg and foot hair loss is a clinical data point your doctor should know about. Research published in a peer-reviewed diabetes journal confirms its correlation with peripheral vascular disease. It is a sign physicians are specifically trained to check for during a foot exam. Most patients never know to report it themselves. Here is what I want you to do. Not eventually. Starting tonight. The single most effective habit you can build after watching this video is a daily foot check. And I mean daily. Not weekly, not when you remember. Here is the exact protocol I give every patient who asks what they should actually do. After your bath or shower, sit in a well-lit spot and look at both feet. you are looking for 5 things. Any new wound, crack, blister, or discoloration you didn't have yesterday. Any difference in skin temperature between the 2 feet. Any new swelling or puffiness. Any change to the nails. And whether the overall shape and appearance looks the same as it has been. If you cannot easily see the bottom of your foot, use a hand mirror. If your vision makes close inspection difficult, ask someone you trust to help you once a week. This is not a large ask. It is 60 seconds. The American Diabetes Association recommends a minimum annual foot examination by a healthcare provider for anyone with diabetes or prediabetes, and a daily self-check at home. Most people don't do the daily check, not because they don't want to, but because they have no system. They have intention, but no structure. The Diabetic Foot Daily Check System is the printed kit I now recommend to every patient who asks what comes next after a conversation like this one. A visual foot map, a 30-day daily log, a laminated red flag reference card, and a doctor visit preparation guide. It turns awareness into a daily habit. The link is in the description. 9 signs. And what I want you to take away from this is not fear. I want to be clear about that. What I want you to carry forward is this. Your body has been giving you access to information that a standard 12-minute appointment doesn't have time to decode. You now have that information. If any of the signs we've discussed today apply to you, please don't put this off. Book a fasting blood glucose test. Approximately $12 at any certified lab, covered by Medicare for most of you. Mention your feet specifically to your doctor, by the names we've used today, not as a bit of tingling or just dry skin. And if you already know you have diabetes or prediabetes, ask your care team to include a formal annual foot examination in your care plan. That is a Grade B recommendation from the American Diabetes Association, supported by strong evidence. Ask for it by name. Before I go, I want to ask you one thing. Think of one person in your life, a family member, a friend, a neighbor, who might be watching their feet and not knowing what they're seeing. Share this video with them. Not as a forward, not as something interesting you stumbled across. Share it as a gift. You might be giving them something they didn't know they needed. And if this conversation helped you today, please subscribe, because this is exactly what I make these videos for. I'll see you next week.